Hello, everybody, ladies and gentlemen, and welcome to the EU delegation to the United States. My name is Michael Curtis, and I'm the Deputy Ambassador. It's good to be with you here today to kick off this very important transatlantic discussion on antimicrobial resistance, which has been organized by my colleagues here in the EU delegation in Washington, D.C., in cooperation with the Infectious Disease Society of America. As we approach the second Christmas and third year of COVID, overcoming the pandemic and preventing future ones is very much part of our work, both in the European Union and together with the United States. But as we try to turn the corner out of this pandemic, we must not forget the insidious threat of antimicrobial resistance, or AMR. This is the nightmare scenario where disease-causing bacteria, viruses, and fungi are constantly evolving and no longer respond to medicines. So collaboration between the EU and the US will be key to manage this AMR threat successfully. We have a history of cooperation on many global challenges on AMR. Together, we can not only make a real impact, but also demonstrate our real commitment to global good in the process. Together, we have already made a substantial effort to reduce the use of antimicrobials in medical care settings, as well as in farming and food-producing animals. Some progress has been made, and this is encouraging. Other countries have also taken steps to control the use of antimicrobials in the Americas with the help of the Pan-American Health Organization, an effort that the EU has directly supported. But despite all of this, and on a global level, antibiotic use in humans, animals, and agriculture is still increasing. COVID-19 has pushed the health agenda to the forefront. It has made our bilateral and multilateral cooperation stronger and has made the public more broadly aware of how pathogens can affect their lives. We need to build on this momentum and apply the same drive, commitment, and collaboration to address antimicrobial resistance, both in our own countries as well as globally. The key to combating AMR, therefore, is intensified and continuous international cooperation at all levels, including academia, civil society, and ultimately, of course, citizens. I hope today's debate will inspire novel ideas and lead to new or renewed partnerships between the EU and the US, as national efforts alone simply won't be enough. Again, thank you for being with us today. It is now my pleasure to pass the floor to Claire Berry, European Commission Deputy Director General for Health and Food Safety, for our opening remarks. Thank you, Claire, and very good to see you.
Thank you very much, Michael, and it's great to see you as well over there in the US. I'm really happy to be able to welcome everybody this afternoon and this morning over there to this transatlantic dialogue on antimicrobial resistance. I think, Michael, as you said, one of the lessons that we've learned from COVID is the importance of global collaboration. It's only really by working together that we can address pandemics like COVID, and indeed the silent pandemic, as we call it, that we have in relation to antimicrobial resistance. We can't do it alone. We have to all work together. So from the EU's perspective, we think that we need a systematic and harmonized response, and we need to boost our pandemic preparedness and to work on reversing the resistance levels. We're looking forward to working with the US, I would say, on all fronts, so bilaterally, under the TAPFAR, and of course globally. And I think what we'd like to do today is hear more about what's happening domestically on your side, but also to explore with you possibilities of how we can work together more effectively internationally. One of the first priorities for us is a new, more comprehensive global action plan. As most of you probably know, we have the global action plan from 2015, but we want to update that action plan, and we'd like to enlist your support in that. And we are hoping that we could put a more strong environmental dimension into the global action plan, because I think that tackling the spread of AMR through the environment is an area where we haven't made as much progress as we should do internationally, and we need to try and put a One Health approach into practice there. Within the EU, we are, as you know, strongly committed to fighting antimicrobial resistance in our farm to fork strategy, which is part of the Green Deal and about greening the agricultural sector. We have said that we would cut by 50% antimicrobial resistance for farmed animals and also in aquaculture by 2030. And we're also, as we speak, actually, in the process of looking at our veterinary medicines regulation and implementing that. And we will be talking to you in more detail about that as we move forward. But the second area, alongside the Global Action Plan that I wanted to mention, is the future global agreement on pandemic prevention, preparedness and response, because we think that that agreement is also another important opportunity to advance work on antimicrobial resistance, in particular around preparedness and response to health emergencies. So we would like also to use that as an area for further cooperating with the US. We have to learn the lessons of the crisis, as we've been saying. We also, I think, have to take the innovations that we've got from the crisis, fantastic things that have happened in a very short time. And I think we need to use those. We shouldn't be proud of those who've worked on antimicrobial resistance. We should take all the benefits that we have, that we see now in terms of the COVID response, and use those. So the heightened infection prevention, control for vaccines and awareness raising, they are all very important in our armory of instruments for AMR. We also need, of course, more developed and more robust surveillance frameworks and a solid supply chain of available antimicrobials, and redoubling, of course, our efforts in relation to prudent use. I think most importantly as well, we have to ensure equitable access to diagnostics, to treatments and to vaccines. And these should be the key for future pandemic preparedness, which will affect all of us. As we say, we need a global response. We would like to strengthen the multilateral structures involved in the fight against AMR. So the tripartite alliance between the Food and Agriculture Organization, the World Organization for Animal Health and the World Health Organization. Cooperation across sectors is essential. We'd like active engagement of all AMR stakeholders in the multi-stakeholder partnership platform, which is going to be launched shortly by the Tripartite Alliance. I think this platform can really be a trigger for change on the ground, on a bottom-up process, to selecting ideas and then pushing them forward at the global and international level. We can't afford this silent pandemic to turn into the kind of pandemic that we've seen with COVID. This is difficult work that we have to do to try and address it, but if we take some collective decisions together, I think we can do it. And obviously, between Europe and the US, we have a very strong and being reinforced partnership, and we would like AMR very much to be a center of that. So I'm looking forward now to a really good discussion. I hope we can be very open. I hope we can be very forthright, and I hope we can come with some ideas about how we can work together now, moving on from today. Thank you.
Thank you, Claire, and thank you to everyone joining us today. I'm Amanda Jezik, and I'm delighted to be moderating today's event. I'm the Senior Vice President for Public Policy and Government Relations at the Infectious Diseases Society of America, a medical society of over 12,000 infectious diseases physicians and scientists on the front line of the fight against AMR. I'm pleased to introduce our next speaker, Lois Pace, Assistant Secretary for the Office of Global Affairs at the U.S. Department of Health and Human Services. Prior to joining HHS, Ms. Pace served as the President and Executive Director of the Global Health Council and spent over a decade working with community-based organizations across Africa and Asia. Ms. Pace, thank you so much for joining us today.
And I want to give my regards to the European Union as well, for co-convening this meeting. On behalf of the U.S. government, it's really delightful to be here. And as has been mentioned by Claire, it really points to opportunities for continued collaboration between the U.S. and those of you, not only at the bilateral level, but also at the multilateral level. So we all know how important this work is on antimicrobial resistance, and we're obviously grateful for this particular convening. I know TATFAR, the Transatlantic Task Force on AMR, was also mentioned, and I want to acknowledge that as a really helpful, useful platform for that type of collaboration, and acknowledge the work of John Ryan, who I know will be speaking later this afternoon. But, you know, this is coming obviously in the midst of an ongoing pandemic with COVID-19 that's just reiterating the importance of our focus on these types of infectious disease threats. But we can't lose sight of this silent pandemic, which is, I know, a way that we've talked about the issue of antimicrobial resistance and really the threats of leaving this unaddressed. We have to look squarely at drug-resistant bacteria and the opportunity that it has, or the risks that it plays in undoing a lot of the work that we have done in the global health space to ensure that we're able to make progress accordingly. Now, this is obviously a priority for the US. It has been, and it will remain a priority for us. Our President Biden has even tasked our White House Office of Technology Policy with setting AMR as a top priority, and all of our federal workforce has taken note of that. We've made a lot of progress as well since the 2015 launch of our own National Action Plan for combating antibiotic resistant bacteria, or CARB. And so we're hopeful that we can continue to move forward and build on some of those gains that we've already made initially as a government. So to that end, I want to be sure that I announce a couple of new endeavors really being housed under our U.S. Centers for Disease Control. That's first off, a network called Global Action in Healthcare, and another that's Global Antibiotic Resistance Laboratory and Response Network. And those are really serving a couple of different functions. The first is more of a comprehensive network looking at addressing these priority emerging infections in healthcare settings and tracking those threats accordingly. And then the other is really focused on filling the gaps in AMR research and surveillance by improving the detection of these threats and identifying those risk factors more readily. Of course, great to be able to announce those efforts, but obviously, a lot more work needs to be done fundamentally on ensuring that our antibiotics can be strong and effective as well. And that's why I'm so glad to be joined today by our esteemed senator from Colorado, who will be speaking next about his proposed PASTEUR Act. And I should express our support and excitement for that particular proposal under consideration in our U.S. Congress. This act would establish both a subscription system and a reimbursement system that would be, we feel, quite effective in this space. And I don't want to steal his thunder by getting too much into those details, but did want to acknowledge that is another important element in our own response here in the U.S. So suffice to say, we plan on accelerating our efforts, building on what's been done, learning from this current pandemic, this experience with COVID-19, to address, again, what we see has been underneath the surface with antimicrobial resistance. Of course, it might not go away completely, but we know that we can do more to mitigate its effects, not just in the US, but around the world. And so we are grateful again for the partnership that we've been able to experience in working hand in hand with all of you. We know that only through this sustained engagement and investment across not just human health, but also animal and environmental health, can we actually make progress. And so in addition to noting the European Union as an important ally in this space, I also want to acknowledge, as others have, the important work of civil society, the private sector, and other country partners in this fight. So thank you for having me. Thank you for continuing to engage the Department of Health and Human Services. And with that, I will turn the floor back to Amanda.
Thank you. And I'm now pleased to welcome Timo Wolken, a member of European Parliament from Germany. Mr. Wolken is a member of the Committee on Environment, Public Health, and Food Safety, the vice chair of the AMR Interest Group, and the co-chair of the Working Group on Innovation, Access to Medicines, and Poverty-Related Diseases. Mr. Wolken, the floor is yours.
Yeah, thank you very much for giving me the floor, and hello from Brussels. I can continue where the others stopped. So the pandemic has reminded the world of the serious threat that emerging infectious diseases can pose to human health and our economies. So the deficiencies revealed, however, have long been recognized in the fight against AMR. So we need to offer alternative treatments and stewardships for health professionals, including the appropriate use in university curricula. Also, monitoring and surveillance is needed to be strengthened, as well as infection prevention and control. So a focus needs to also be put on better access to rapid and affordable diagnostic tools. but also other measures need to be taken. As Claire rightly mentioned, the use of antibiotics in veterinary medicine, for example. We need to have to put a stop to any use of antimicrobials in animals that does not correspond to prudent or responsible use. So the use of antimicrobials and other pharmaceutical substances should not be allowed in order to compensate for poor animal husbandry practices. Moreover, measures such as introduction of continuous monitoring of AMR in the environment, sorry, or greater transparency in antibiotic manufacturing throughout the entire supply chain are needed to mitigate the impact of pharmaceuticals in the environment. So, companies have to be held accountable for the environmental release of pharmaceuticals from manufacturing plants and those operated by third parties at any stage of production. And lastly, we need to find solutions to combat the market failure. New antibiotics are often associated with a lack of profitability for pharmaceutical companies, as their development is costly and their lifespan on the market is short due to the developing resistances. There is really the need to support needs-driven models to finance and stimulate antibiotic research and development. So we should, for instance, rethink the economic model so that revenues are not dependent on the volume of sales as a means to ensure both affordability and rational use for conservation of effective antibiotics. There are different models like the subscription model or the transferable market exclusivity voucher. Whatever the best solution is, it has to ensure both responsible use and equitable and affordable access to quality antibiotics, taking an end-to-end approach, which targets public investments across the entire chain from global priority setting to early discovery, through the product development phase to appropriate and affordable patient access. Keeping antibiotics effective is indeed everyone's responsibility. Therefore, we have to ensure that AMR is high not only on the EU policy agenda, but on the global one. So there is the need for urgent action through a cohesive and ambitious multi-sectoral One Health approach, which addresses human, animal, and environmental health. The time to act is now, and we have no time to waste. This fight can only be won when we act together globally. So thank you very much, and I'm now giving the floor back to Amanda.
Next, I'm delighted to introduce U.S. Representative Shelley Pingree of Maine. Representative Pingree was elected to Congress in 2008, and she currently serves on the Appropriations Committee and the Agriculture Committee. I have had the honor of working with Representative Pingree and her talented staff for the last several years, as she has spearheaded an annual bipartisan effort supported by over 60 of her colleagues in the House to increase federal funding for activities to combat AMR at the CDC, NIH, and BARDA. Representative Pingree, thank you so much for being with us today.
Thank you so much, Amanda, for this, your kind introduction, and it's a pleasure working with you. I also want to just thank the European Union delegation and the Infectious Diseases Society of America for hosting. It's been great to work with IDSA on funding AMR efforts over the past several years, and I am glad that we're adding a global lens to this discussion today. So thank you to everyone who's participating. As so many of you have already mentioned, the COVID-19 crisis has really underscored the strengths and all too often our weaknesses of the public health infrastructure. Though we are still clearly in the middle of this devastating pandemic, we cannot lose sight of preparing for future challenges. We all agree and know this very simple fact. Antimicrobial resistance is present, serious, and growing threat to public health in the United States and around the world. There are clearly a complex web of factors contributing to the threat, from agricultural systems that overuse antibiotics to poor water infrastructure that allows microbes to thrive. Ultimately, healthcare systems are faced with increasingly resistant infections and fewer effective treatments. It's difficult to capture the full impact, but the United States CDC data estimates 2.8 million resistant infections in 2019, causing at least 36,000 deaths and costing $4.6 billion to our healthcare system. But those are only US statistics. And as we've all learned, and you're all here today, in our interconnected world, we're only as prepared as our neighbors in facing infectious disease. So Congress needs to provide resources now, both to bolster our own preparedness and to help with those global needs. A complicated problem like AMR requires comprehensive solutions. As you heard, I serve on the House Appropriations Committee, which provides a whole of government perspective on how to fight for more funding and better oversight. I've been working on efforts to secure funding for a wide variety of programs, including CDC's antibiotic resistance solutions initiatives, NIH's work to build research capacity, and BARDA's efforts to boost the antibiotic development pipeline. My colleagues and I are pushing the FDA to establish stricter guidelines on how to use antibiotics in agriculture in a more targeted and effective way, and we all know how critical this is. The House has also included substantial increases to global health security programs and water infrastructure efforts in our proposed FY22 spending bill, and we're working hard right now on moving that across the finish line. The good news is that in the United States, many of these efforts are strongly bipartisan. While bipartisan interest is positive, we need to make more progress, and we need to do it quickly, as so many of you have said. I'm working to impress on our congressional leadership and the administration that substantial investments to fight AMR can't wait. We have learned so many lessons so far from COVID-19, and they are both a warning and an opportunity. With foresight, coordination, and resources, I know we can make an impact now that saves countless lives around the world. So again, thank you to the organizers for hosting this important event. I really am looking forward to collaborating with all of you as we join efforts to fight antimicrobial resistance, one of the most critical issues we deal with today. Thank you so much.
I now have the honor of introducing our final speaker before the panel, Senator Michael Bennett of Colorado. Senator Bennett has served in the U.S. Senate since 2009, where he's recognized as a pragmatic leader on a variety of healthcare issues, including AMR. In 2016, he sponsored the PATH Act, which became law to create a new streamlined approval pathway for novel antibiotics that address unmet needs. Now he's the lead sponsor of the bipartisan legislation to revitalize antibiotic R&D and support appropriate use of antibiotics, the PASTEUR Act. Senator Bennett, it is such a privilege to work with you and your terrific staff on this important issue, and we look forward to your remarks today.
Thank you so much for having me. Hi, everybody. I am Michael Bennett. I represent Colorado in the U.S. Senate, and it is a great pleasure to speak to you for a few minutes about the important issue of antimicrobial resistance. I want to thank the EU and the Infectious Disease Society of America, especially Amanda, for having me and for hosting this important panel conversation on AMR. Thank you as well to Ambassador Curtis and to Claire Bury, to Secretary Pace, to Member of Parliament Mr. Wolkin, and Representative Pingree for being here as well. I'll be brief because you've got a wonderful discussion immediately following my remarks I don't want to get in the way of, but I do want to highlight how important it is to have a strong response to address AMR in the US in partnership with the EU. Bacterial infections caused by drug-resistant microbials kill 35,000 Americans annually, and they are expected to be the leading cause of death in the world by 2050. That bears repeating. AMR will become the leading cause of death, not cancer, not heart disease, or malaria infections. We can't continue speaking about resistant infections becoming the leading cause of death in 20 to 30 years and not do anything about it. And if you're looking at this in the context of COVID-19, which my constituents are, it's clear that we were unprepared for the pandemic. And as a result, COVID has been so costly for the US and the rest of the world. And in my mind, there are at least two key lessons from the COVID-19 pandemic that we should be applying. First, we can't sit on our hands and wait for the next crisis to arrive. We need to anticipate the crisis and act now. Second, there is no national solution for an international problem. Infections don't care about borders or political jurisdictions. We need a coordinated international approach to keep us safe from global threats to public health. And that's why I've worked with Senator Todd Young from Indiana to introduce the PASTEUR Act, which in our view is the strongest bill ever written to strengthen antibiotic development and improve appropriate use of antibiotics. Right now, the system in the US rewards volume, not value. It's led to massive overuse of antibiotics, which has driven down reimbursements, and with it, the incentive for private investment in research and development. Under the Pasteur model, we would transition to a subscription model. The government would say to pharmaceutical companies, we're going to give you anywhere from $750 million to $3 billion to develop the next generation of antibiotics. But in return, you have to be better stewards of antibiotics. The Pasteur Act aims to create a system where payment is rewarded on the value of the drug to patients, not the volume of the drug produced, and a system that ensures drugs are used appropriately and not because there's a guaranteed reimbursement each time they're used. A system that encourages working with other countries on similar types of subscription payment models, which we believe will encourage efforts like those already underway in Sweden. We believe strongly that the approach we've laid out in the Pasteur Act captures the direction we need to head as a country, but also as an international community. In fact, we can't do it without the international community. I look forward to your continued partnership as we work to get this done in the next year. Thanks again. I really appreciate your inviting me to share a few words. And with that, I'll turn it back to Amanda. Have a great panel.
I want to thank all of our opening speakers, and now I'm pleased to introduce our panelists. John Ryan is the Director of Public Health in the European Commission and also Deputy Director General for Health of the Directorate General for Health and Food Safety. He leads on AMR. Dr. Larry Kerr is the Director of the Office of Pandemic and Emerging Threats in the Office of Global Affairs at the U.S. Department of Health and Human Services. Professor Anthony So directs the Strategic Policy Program of REACT, Action on Antibiotic Resistance, at the Johns Hopkins Bloomberg School of Public Health. And Dr. Reshma Ramachandran is a physician fellow at the Yale National Clinician Scholars Program and leads efforts for Doctors for America on prescription drug pricing and FDA regulatory policy. We welcome questions for the panel from our audience. You may submit your questions through the webpage through which the panel is being streamed. I'm excited to dive more deeply into AMR issues with this terrific panel today. IDSA has been working on AMR since 2004, and we've been so encouraged to see many more organizations and countries prioritizing this issue. While we've seen a lot of exciting progress, the threat of AMR continues to grow, and our pipeline of new antimicrobials remains extremely fragile. John and then Larry, can you each share what you view as some of the most important recent progress on AMR? And tell us about how the new TATFAR work plan will build on that progress and address some of the persistent challenges we're facing.
Thank you very much. It's a great privilege to be here and to address so many distinguished colleagues. I wanted to say that I think antimicrobial resistance is not something which you can sort out in a very, very short period of time. I think a systematic, what we call a One Health approach, is probably the recipe for a successful outcome. And that's why the European Union has taken this approach of a holistic, integrated approach to antimicrobial resistance, looking at different angles, looking at the pharmaceutical angle, the research angle, how antibiotics are used in human and animal medicine, and of course, as my colleague Claire Burry said, the protection of the environment and antibiotics in the environment. So there are many aspects to this, and I think the European Union has tried to bring these different strands together into a single action plan. And the action plan has the ambition to make the European Union a best practice region, to boost research, innovation, and development of new antibiotics, or alternatives indeed. And thirdly, and probably most relevant for today, it's sharing and shaping the global agenda. So working very closely with international organizations, international partners. So we're now in the full implementation phase of this action plan since it was adopted in 2017. We've been, for example, introducing legislation on veterinary medicine and medicated feed. We've been working together internally with our European Centre for Disease Prevention and Control and the member states in order to support efforts to improve surveillance and exchange of good practice in human health. We've been trying to support infection prevention and control measures, antimicrobial stewardship in our health systems funded by our health program. Now, all of this is very relevant for our cooperation with the United States in the TATFAR arrangement, the Transatlantic Partnership on Antimicrobial Resistance. And I'm happy to say that we work very, very closely with our colleagues in the United States in order to find topics relation to antimicrobial resistance where we have a common interest and where we can work together. The issue is not to find these issues of common interest because we have so many of them. The issue is to prioritize where we can work in a concrete way together. And all of this is reflected in our work plan. And I'm very happy to say that we have just adopted a new work plan for the next period, which I hope will be able to steer us for the coming years. And also, we've opened up our partnership to Canada, Norway, and the United Kingdom most recently. So this is really good news that we're bringing more and more people into the fold and sharing information, experience, and projects together. Thank you.
John, thank you so much for those introductory remarks. And I want to thank the EU and IDSA. Amanda, thank you for your championship of AMR as a critical issue over all these many years. And I'm honored to be on this distinguished panel. I'll just continue where John left off, and that is TATFAR has made significant progress in the fight against AMR during its initial 2016-2020 implementation period. And I would offer that you can read about the progress that was made on the TATFAR website. The new TATFAR work plan is going to continue to build upon this progress in a number of activities, but I'll just mention a few. So for example, the promotion of diagnostic stewardship by expanding information on challenges and opportunities related to integrating laboratory and diagnostics with antibiotic stewardship actions. Mathematical modeling to accelerate AMR prevention and control efforts. We're revising definitions for multi-drug resistant, extensively drug resistant, and pan-resistant bacteria for human infections for better surveillance efforts. Exploring sewage-based surveillance measures to monitor AMR, just as a few examples. But TATFAR recognizes that AMR is a complicated multi-sectoral issue. And in addition to posing a significant threat to human, animal, and environmental health, AMR also has dire consequences for the structure and sustainability of healthcare systems, agriculture, and environmental industries. And that is where TATFAR members continue to approach AMR through this multi-sectoral lens. And TATFAR working groups cover a very wide range of topics with multiple disciplines included from memberships from a wide variety of sectors. The new TATFAR work plan recognizes the need to include policy in AMR conversation, and the TATFAR Policy Working Group convenes policy experts to present on and discuss policy topics related to AMR. You've heard already Lois mention, for example, CDC's announcements of 2 initiatives that will be integrated into work streams, the Global Antibiotic Resistant Laboratory and Response Network and the Global Action in Healthcare Network. These initiatives and those along with our EU partners and those in TATFAR will work to fill gaps in AMR research and surveillance, and will collaborate to grow laboratory expertise and to detect AMR threats. So back to you, Amanda.
The COVID-19 pandemic remains top of mind for us all. Infectious diseases physicians report that our antimicrobial stewardship teams have routinely had to divert their attention away from their missions of optimizing antibiotic use to instead managing the very complex administration of COVID-19 therapeutics. At the same time, some of our most seriously ill COVID-19 patients, especially those requiring ventilators and long hospital stays, are further compromised by hospital-associated infections, many of which can be multi-drug resistant. In your perspective, how has the pandemic impacted our responses to AMR, and how is AMR complicating our response to COVID-19? Larry, why don't we begin with you, and then we can have some others weigh in.
Well, thanks very much, Amanda. And it's a phenomenal question because it is unfortunate that during the pandemic, much of the progress and work done to combat AMR experienced setbacks. And as a result, we have seen resistance numbers rise. Data collected during the pandemic last year indicated that patients with COVID-19 may be more susceptible to getting a secondary infection while hospitalized, and infections that occur while in a hospital are more likely to be caused by resistant germs. Additionally, during the pandemic in 2020 data, some pathogens, including methicillin-resistant Staphylococcus aureus, MRSA, caused more hospital-onset blood infection overall in all patients, not just in those with COVID-19 infections. There have also been outbreaks in antibiotic-resistant Acinetobacter and Candida in COVID-19 units, most likely from infection control lapses caused by pressures of the pandemic, like increased hospitalizations and PPE shortages. In hospitals, antibiotic use increased, likely reflecting the difficulties in distinguishing COVID-19 from community-acquired pneumonia caused by bacteria when patients first arrived for inpatient health care. In outpatient settings, we saw antibiotic use drop significantly, but this is likely because outpatient healthcare use declined during the pandemic. Azithromycin prescribing was higher than expected, especially in geographic areas with high numbers of COVID-19 cases. This might be a reflection of its early promotion as a potential therapy despite its ineffectiveness against viruses. The number of bacterial and fungal specimens and isolates received and tested in 2020 by CDC's antibiotic-resistant lab network was only about 23% less than 2019 levels. This may be because healthcare facility and public health staff had to shift to COVID-19. Overall, the data demonstrate the pandemic impacted our AMR response mainly because of the capacity and resources for AMR were quickly diverted to COVID-19, and there weren't plans in place to maintain the AMR efforts. AMR then also complicated the COVID-19 response because many patients are developing secondary bacterial and fungal infections, leading to increased use of antibiotics, further increasing the chances for resistant bacteria to develop and spread. Back to you.
Would others on our panel like to weigh in on this question? John, how about you?
I'll just say a word and then hand over maybe to Anthony and Reshma, I beg your pardon. So from our perspective, I confirm what Larry has been saying. There has been a substantial and consistent decrease in antimicrobial consumption in the community, mostly in primary care settings, in most of our European Union countries between 2019 and 2020. And we think that the factors which are related to the COVID pandemic also had an impact. For example, changes in disease transmission, healthcare utilization patterns, or prescription patterns. Don't forget that there were a large number of people who were not able to access primary or even hospital care at certain times during the last 2 years because of the situation in the pandemic. And therefore, this may be actually compounded by the fact that a lot of the non-pharmaceutical interventions like mask wearing, physical distancing and so on may also have reduced transmission of certain respiratory tract infections, and that might have also played into the equation. The latest data from the European Centre for Disease Prevention and Control does show high levels of antimicrobial resistance for several important antimicrobial group combinations, and therefore the problem hasn't gone away. I think the COVID has upset the situation, but it hasn't made it go away in any sense. From an economic point of view, I'd also like to mention that the political impact of COVID has been enormous because of its spread across society and the international implications. And I think we've been trying to pass the message that while COVID is a defined problem, antimicrobial resistance is a slow running flame, and we really feel that we've been trying to link COVID with antimicrobial resistance in people's minds so that they're aware that COVID is one problem. Antimicrobial resistance is certainly going to hit us sooner or later, and we really need to be prepared for that. And finally, on the economic side, as I said, a lot of investment has been made in dealing with COVID, and this may result over time in a reduction of the investment in antimicrobial resistance. And that's why we've really been trying to link these two issues in political terms together. Thank you.
Anthony, any final thoughts on this question?
Sure. Thank you first of all for the opportunity to join this timely and important discussion on AMR. I think the intersection with COVID-19 really provides a teachable moment. So in many ways, at the global level, taking it really beyond even the US and EU, of course, the pandemic has put our healthcare systems through a major stress test. And we're discovering really where it's coming up short, despite heroic efforts by healthcare workers everywhere. And the challenges have played out for both what we would call AMR sensitive interventions and also AMR specific interventions. So against this backdrop of really challenging COVID-19 vaccine inequity, we've seen setbacks in the hard-fought gains that Gavi, the Vaccine Alliance, UNICEF, WHO, and among others have made over the past decade. Vaccinations are a hugely important AMR-sensitive intervention that help us to reduce the use and thereby the selection pressure on antibiotics. Yet 23 million children in 2020 missed out on basic vaccines usually delivered as part of routine health services. And that's more than we've seen in over a decade. Not since 2009 have we seen such numbers. Up to 17 million of these children didn't receive a single vaccine during the year. And then if you turn to our hospitals, of course, we've seen challenges of delivering AMR-specific interventions. We learned how hard it was to scale N95 masks for healthcare workers at the start of this pandemic. But even before COVID-19, 1 in 4 healthcare facilities globally did not even have basic water services, rather essential for hand hygiene and infection prevention control. So the pandemic has created a teachable moment for an ongoing problem of AMR. And I think we just need to remember, of course, that this ongoing toll from drug-resistant infections, which the UK review on AMR put at 700,000 deaths a year, even before the pandemic. But we also must remember that up to 5.7 million people die from treatable infections each year, most in low and middle income countries, many because they lack access to effective antibiotics. And this points to the story of underuse, not just overuse, the need for addressing access and not just excess. So there is, of course, a significant challenge to tackle across the board for AMR.
So as Anthony rightly said, the pandemic presents a very teachable moment. So how can we ensure that AMR is part of the broader discussions around pandemic preparedness? And how can we best apply the lessons learned from the COVID-19 pandemic to strengthen our approaches to AMR? Anthony, why don't you start us off? And then I'd like to hear from John and Reshma.
Sure. Yeah, while it's true that a viral pandemic may take a different form than the ongoing one for antimicrobial resistance, there are some common touch points, places where we might make investments that would return dividends in preparing, preventing, and responding to the next pandemic. And so we can go for twofers in some ways, right? These include the need for improved efforts to trace and halt zoonotic disease transmission, to support integrated disease surveillance. And I was really pleased to hear that there seems to be interest, particularly in sewage-based surveillance. I think we need to scale to a global wastewater surveillance system that could serve as early sentinel to the next emerging disease threat. We need to obviously ensure effective infection prevention control, from PPE to respiratory support and oxygen therapy. And we need to build surge capacity for delivering the health commodities we need, from diagnostics and vaccines to therapeutics. So, while tackling AMR and COVID-19 may require distinct strategies, perhaps we can begin by finding common cause. For example, building that global wastewater surveillance system might spot the next outbreak before it becomes a pandemic. And this has been proposed for drug-resistant infections several years ago, and is how we are now, of course, using the infrastructure of the global polio laboratory network to track COVID-19. And a logical next step might be to build the surveillance of drug-resistant infections onto this existing infrastructure as well.
So maybe I could come in, Amanda, and just say a few words about how we've been trying to learn lessons from the COVID outbreak, even though it's continuing as we speak. First of all, I think we have legislation at European Union level on serious cross-border threats to health. We also have, of course, our two relevant agencies in this case, the European Medicines Agency, the European Centre for Disease Prevention and Control. And we've taken the opportunity over the last few months to develop strengthened legislation for cross-border health threats, broadly aligning ourselves with the international health regulations, by the way, but allowing a stronger coordination within the European Union and its 27 member states in order to make sure that our response is coordinated properly. So we're strengthening our surveillance, our preparedness planning, and our coordination of response. We have secondly set up, inspired by the US BARDA system, we have set up a European Preparedness Authority, which will focus on preparing for cross-border threats from the point of view of pharmaceutical countermeasures. And this is actually being set up as we speak. Thirdly, we have a pharmaceutical strategy for Europe, which is in the process of being rolled out at the moment, and which will also include pull incentives, in other words, to bring novel antibiotics on the market and address market failure. And lastly, we have adopted quite strong financial instruments in order to enable member states to build back after the pandemic, a little bit like you have as well in the United States. So the health systems have already benefited from about 50 billion euros of new investment during the pandemic, and this will continue afterwards. We also have specific support then for initiatives related to AMR. And finally, I had mentioned the perspectives we have in Geneva for the global agreement on pandemic prevention, where we hope that antimicrobial resistance can somehow be linked actively into this negotiation so that people have antimicrobial resistance from the very beginning on their radar screen when we're talking about pandemics. Thank you.
Reshma, final thoughts on this question?
Yeah, so I'll just pick up on some of the things that were mentioned both by Anthony as well as John in relation to BARDA and really other federal agencies that have been so pivotal during COVID-19. It can't be understated the role of BARDA and these other agencies in being just nothing short of really remarkable in their ability to rapidly spur the development of COVID-19 health technologies, vaccines, diagnostics, and therapeutics. But there are, definitely some lessons learned in terms of how to think more long-term around the challenges of who ultimately, and especially during a public health emergency, and in with this slow rolling public health emergency that we're seeing with antimicrobial resistance, on who will protect access. And so one actionable area to consider would be to look more upstream at these agencies, how BARDA in the United States or a BARDA version in the European Union could create an enabling environment through their agreements with different manufacturers in granting significant taxpayer funding by including provisions that would ensure a fair return on this public investment, especially when this public investment significantly removes the risks for a number of manufacturers to even enter into the space. This might include allowing for the technology to be shared with multiple manufacturers across the globe to ensure an adequate supply, and also provisions to ensure a fair price for the health technologies that are ultimately developed as a result of this support. And in that way, BARDA can ensure that access is not just an afterthought, but really an integral component of the integration ecosystem that it's seeking to foster, and a way that we can make sure that antimicrobial resistance is addressed globally around the world.
In September, the WHO released a comprehensive review of its global action plan on AMR, indicating the levels of progress made in the many facets of the global response. Notably, virtually every aspect of our work on AMR requires more attention and more progress. John, what do you view as some of the key takeaways from this report? Then I'd like to hear also from Reshma and then Anthony.
So, first of all, I'm pleased to see that plant health and the environment are taken into account, and also the call for more inclusion of the United Nations Environment Programme and environmental issues within the Global Action Plan. So that's already a better One Health approach from our point of view. Addressing antimicrobial resistance through the environment is crucial if we want to have a proper One Health approach, and global action in this area is currently lagging behind. So I'm very happy with this first focus area. Secondly, we have been trying to adopt this type of approach in the European Union with our approach to pharmaceuticals in the environment, which we adopted in March 2019. I'd be very happy to share that with our US partners, so that you can see what approaches we're taking. This action on pharmaceuticals in the environment contains actions across the whole life cycle of pharmaceuticals, including antimicrobials, and addresses some of the AMR challenges as regards the environment. We've seen with COVID, I think, how quickly scientific research can lead to breakthrough vaccines. And I think we could also use this opportunity to address this issue with antimicrobial resistance. Supporting science through novel pull incentives could bring new antibiotics on the market, as well as access new diagnostic tools, treatments and vaccines, which is of course key for future pandemic preparedness. That's why I think more cooperation at the global level is better than less cooperation. It's really important, and this is emphasized in the report. We also think, by the way, and it's reflected in the panel today, that civil society, the private sector, and academia, the whole research community, need to play a key role in the fight against AMR, involving them in the policy dialogues that we're having and the policy choices that are being made, so that we should encourage and take into account their contribution. And we think as well the idea of AMR targets and indicators at the international level is a place we would like to go to as well. Thank you.
Reshma, let's go to you.
Sorry, I went on mute. So it was heartening to see the comprehensive review from the WHO, and there's some areas that they've definitely highlighted, but obviously some gaps that have been noted by both John but also Amanda as a part of the question. Kind of as a recurring theme, there was a focus on excess, really on the overuse and misuse of antimicrobials, but really less so on the access concerns and the underuse concerns that we're hearing from a number of our colleagues, especially in low middle income countries, to effective and appropriate antimicrobials. There was also some missed opportunities to really highlight some of the areas, particularly around access, that the WHO and civil society have raised in light of this, particularly around like the unstable supply of benzathine penicillin G for rheumatic heart disease, a disease that we know is primarily and disparately affecting the global South, as well as the supply barriers that we're seeing currently amidst COVID-19 that have been exacerbated amidst the pandemic to liposomal amphotericin B for mucormycosis, which is a particularly devastating disease for a number of populations in the world who have been impacted by COVID-19. On top of that, I think there's this other kind of concern that has been raised in terms of the role of civil society, not just for informing some of the downstream efforts around access and stewardship, especially on the ground in these countries, but really even thinking about their role in informing some of the indicators that would be pursued by the WHO in evaluating efforts both globally but also at the national level. There's this risk of WHO really losing its global normative leadership role to industry-funded efforts, including the AMR Action Fund. And so as a complement to this, thinking about ways that civil society and other independent experts can help strengthen the WHO's role amidst this pandemic and amidst this concern around antimicrobial resistance, and to inform these indicators specifically.
I might add to this, Amanda. I think Reshma covered a lot of important ground. Clearly important gains have been made in creating national action plans and in selected areas like the R&D pipeline for novel technologies to tackle AMR. That includes things like priority pathogens, the creation of the WARE classification with the essential medicines list. Of course, their important work on tracking the antibiotic pipeline. But the comprehensive review is eye-opening in its frank and quite critical appraisal of how well we are faring now 6 years into the WHO's Global Action Plan on AMR. And I would really commend its very close review, particularly by member states, because we really do need to take stock of where we are and see where we might in fact improve our efforts. The AMR governance structure, as the comprehensive review points out, has really not come together in a way that engages the breadth of international agencies that must be engaged. The tripartite agencies, which include, of course, WHO, FAO, and OIE, really should become a quadripartite. I think it's mentioned several times actually in the report, and that would make the UN Environment Program a more equal partner in this effort, which I think would also reinforce, I think, what the European Union's very clear position on actually trying to lift up environment really into this, into a One Health approach on AMR. But we also need to enlist more proactively the work of other international agencies, the reach of UNICEF in childhood vaccination campaigns and on neonatal sepsis, the UN Development Program in making this a development challenge, and the World Bank in making the case for AMR from a development economic vantage point. And the WHO and the global AMR governance system that we've put in place really have not mobilized financing required to carry out its work, nor ensure the necessary accountability to deliver on the Global Action Plan on AMR. Only 1 in 5 countries had identified funding for their national action plans. And nearly 40% of countries did not even have a budgeted operational plan for AMR. So it's great to have on paper the national action plan, but unfortunately, implementation requires more. Now, this really important finding actually about the shortfall in financing comes at a time when the first round of national action plans on AMR are expiring. Still some not financed nor implemented, but they're up for renewal. So I think we're going to have to do more if we're going to really expect the next round to actually deliver milestones. And while there were some methodological reasons for the change, it's unfortunate that the latest tripartite country self-assessment survey that gave us a picture of how underfunded NAP or National Action Plan implementation was, no longer carries a question on the adequacy of funding the National Action Plans in this latest version. Now, this is a new approach to accountability, removing the offending measure. However, I humbly suggest that will not solve the problem. And the challenge is, though, is not just at the country government level. Now, since 2019, only $18 million have been raised for the multi-partner trust fund on AMR. And this goes largely to support the tripartite agencies and a very small sum for UNEP in country-level efforts. And yet this is barely a rounding error compared to actually what is expended on COVID-19. The comprehensive review of the Global Action Plan on AMR calls on the WHO's Division of AMR to improve its work across a broad range of areas, from falling short on enlisting actually other multilateral and international agencies, not engaging effectively civil society, the need to do more to track actually and benchmark progress on AMR, and making the case for the greater financing of this global health challenge. And now we know firsthand, I want to point out that we know firsthand how excellent, hardworking, and deeply skilled the technical expertise of the WHO staff involved are. It is clear, though, that the WHO's own comprehensive review, though, recommends that its work on AMR needs to take some steps to improve how it mobilizes stakeholders, raises resources, and engages with civil society. So we hope that the member states will bring this report to the WHO Executive Board meeting in January so that we can begin to address the recommendations. And I hope the United States and the European Union will be helping to lead that effort for greater accountability.
Let's take a deeper look now at some of the individual components of our response to AMR. We know that antimicrobial stewardship is critical to guide optimal use of antimicrobials and reduce inappropriate use. How would you characterize our progress on stewardship, and what more needs to be done in this area? Reshma, let's begin with you.
Yeah, thanks. I'll speak more from a clinical perspective as a practicing physician. And I think some of the efforts have been highlighted here today, both at the government level, but even on the ground. From my perspective, working and seeing patients, both in the inpatient and outpatient setting, I have seen progress over time. in terms of having health systems put protocols in place, having checks on antimicrobial stewardship, particularly through the development of stewardship committees that are interdisciplinary, to be able to look out for misuse or overuse of particular antibiotics, especially those for broad spectrum use that should be second line and not used immediately. We've also seen clinical guidelines that have been continued to be adapted to examine things like the duration of antimicrobial treatment as an opportunity for stewardship of both adult as and especially of pediatric populations. And I will say, you know, this has been ongoing in the European Union for some time, and we here in the United States are catching up in terms of re-examining how we actually dispense antibiotics and administer antibiotics to our patients. However, there continues to be significant gaps, primarily, I think, very upstream, and I think we'll talk a little bit more about this later, around educational efforts, of course, and thinking about stewardship, more importantly, in the context of innovation. We have a number of incentives for innovation that are coming, that have been proposed, that have been implemented, but oftentimes stewardship is not coupled as a part of these incentives, or is seen as an afterthought, kind of divorced from the incentive for a specific antimicrobial. And so I think the question is, you know, how can we best think about stewardship as a way to incentivize health systems and providers not just to administer antibiotics and administer these new antibiotics, but really as part of that sort of clinical model. How can we build it in, you know, upstream in the policy measures? As someone on the health services research side who has been looking at indication labels for antibiotics, for instance, from the FDA and other regulatory agencies, it's been pretty remarkable to see kind of the lack of stewardship even being mentioned as a part of these labels. So as a clinician, these labels inform our use of these antibiotics, yet if stewardship is not a part of that sort of indication label, there's a missed opportunity there to really instill the importance of conserving these antibiotics for appropriate patients and appropriate pathogens, instead of perhaps administering it more wholesale and inappropriately. So I think there's a couple of areas here, both, you know, high level in terms of policies that we can address on the regulatory side, and even thinking about incentives for innovation to build in stewardship, and really downstream, even at the point of clinical care and within medical education as well.
Great points, Reshma. Thank you. I know I hear frequently from IDSA members about the need for more resources to support the implementation of stewardship in all of our healthcare facilities. And certainly that's something that the PASTEUR Act would really help with. And I think that is a great example of exactly what we were talking about, the importance of really coupling incentives for innovation with stewardship. John, would you like to weigh in next? And then we can go to Anthony.
Yes, thank you very much. I'd like to weigh in maybe on the animal health side, because we haven't said too much about our animal friends so far. Maybe on the international level, a point I'd like to mention is that I think there's great scope for intensifying our efforts together for improving animal welfare, good hygiene practices in farms, using feed additives to improve disease resistance, vaccination, and good breeding practices in general. This is something we're actually quite active in the European Union. We organized a major series of conferences, for example, quite recently in Southeast Asia, in order to bring together animal health and human health experts in order to discuss some of these issues. The prudent use of antimicrobials in the farming sector and among veterinarians is extremely important, raising the profile of this topic, not only on the human health side, but also on the animal health side. I think that's a point I'd really like to put out there as you know, something where we could really work together, I think, in the coming years. At the European Union level, we've adopted a new regulation which will enter into force on the 28th of January of next year. And this will provide for a series of concrete measures to fight antimicrobial resistance and promote prudent use of antimicrobials in animals. For example, there is a ban on the use of antimicrobials in animals for promoting growth, a ban on the preventative use of antimicrobials via medicated feed, a ban on the preventative use of antibiotics in groups of animals, and the possibility to reserve certain antimicrobials for human use only, or indeed the compulsory data collection on sales and use of antimicrobials. So this piece of legislation is really quite important, coming into place in January. The latest statistics which we have show that there is actually a substantial decrease in the consumption of veterinary antimicrobials. We're talking about decrease of over 40% in the period 2011 to 2020. So the efforts which we've taken already have been quite significant, and we have measurable outcomes. But I think it's important that we continue these efforts, and particularly on the international stage. Thank you.
Anthony, any final comments on this question?
Sure. I mean, I think building, of course, on what John said, of course, what the European Union has been doing is just laudable in curbing antimicrobials in use in food animal production. We here on the US side could probably take some lessons from their efforts. Clearly, sales for antimicrobial use in livestock actually on this side, which account for 2/3 of the medically important drug sales in the US, actually rose for the last 2 years of reporting here in the US. And our civil society partners actually have called upon the US administration to publicly announce really time-bound numeric targets for reductions on the US side to curb routine administration of antibiotics to herds that are not sick animals. That's where prophylaxis is a problem still in this country. And also to close the data gap on how antibiotics, of course, are used on farms by directing the FDA to begin collecting actually these medicated feed distribution records. But what's really exciting on both sides of the Atlantic, even, we don't just leave it to governments. Importantly, consumer groups are calling upon restaurant chains and grocery stores not to source food animal products raised with the routine use of antibiotics. The chain reaction report here in the States, and of course, the work of the Alliance to Save Our Antibiotics in the UK on grocery stores have been really outstanding examples, of course, of how civil society has really complemented the efforts of government to help move actually the entire food value chain towards one that actually recognizes the importance that consumers place on having foods sourced without the routine use of antimicrobials. We have a lot more to do, though. The World Organization for Animal Health documented that 42 of the responding countries, or over a quarter, still acknowledge that they allow the use of antibiotics for growth promotion. That's just the starting point, actually, measure that we need to have. And yet there's still so many countries not yet there. I would just really also want to just bring in the environment because, again, that's so important in our discussions. No matter what we do in the healthcare delivery system and also in the food system, we have to take into account that third part of the One Health triangle. And that's because up to 80% of antimicrobials consumed by humans or animals can end up excreted into the environment. And so whether it's runoff from factory farms or the lack of sewage infrastructure in urban settlements and resource limited settings, we have a large underappreciated problem of antibiotic pollution. And I would point out the UN Environment Program is preparing a report on the environmental dimension of antimicrobial resistance that they hope to put forward. We've been honored to be part of the writing group contributing to this. But we should be looking at those intersections in the environment that are yet essentially not fully delineated. Microplastics, we know in the environment, actually speed up by many-fold the genetic exchange of determinants of resistance between bacteria. Herbicides like glyphosate changes the response of enteric organisms on how susceptible they are to developing drug resistance. And methane gas emissions in some studies are now being suggested to have significantly increased in cattle treated with antibiotics. So here we have a 1.8 times more methane gas emission, a critical, of course, potent greenhouse gas that might in fact be increased if in fact we continue antibiotic treatment of livestock. These are some of the tantalizing yet still to be explored actually scientific findings that we must actually understand better if we're going to reach a tipping point on AMR. So I hope that's also useful context as well in rounding out the comments before.
So incentivizing the development of novel antimicrobials is another very high priority area. Senator Bennett discussed his legislation, the PASTEUR Act, which a wide array of experts have endorsed. Larry, it was so great to hear Ms. Pace's very encouraging comments about PASTEUR. What perspectives can you share on antimicrobial R&D incentives?
Sure. Thank you, Amanda. And yes, it was great to hear Senator Bennett's remarks. Clearly, there is wide agreement that a tangible and accessible solution to incentivizing antimicrobial development is to revalue antibiotics through novel or modernized reimbursement models. And as Lois mentioned during her opening remarks, the U.S. has taken steps to evaluate our own system and implement changes within our current authorities. But we agree that much more needs to be done, and we are prepared to do so. recognizing the importance and the impacts it could cause if dedicated action is not taken, we are very encouraged to see the PASTEUR Act introduced in Congress and are very hopeful for its positive outcome. In addition to the PASTEUR Act, though, the U.S. is currently working with global partners in multiple venues on this issue. For example, in the G7, working groups are already working to develop and promote suggesting economic incentive options for countries to consider, including shared valuation principles that can influence how the G7 countries reimburse for these drugs, strengthening antibiotic manufacturing and distribution pipelines, and shoring up global manufacturing requirements in order to limit environmental impact. Some countries have domestic efforts underway. Norway and UK have implemented pilot subscription programs, and the EU, Germany, and France have proposed procurement programs. And we will see how these play out in the coming future. So while the country has had to, each country has to adhere to its national context, and various systems are different, there is much to learn from one another that can be leveraged to create global movement on economic incentives. And we very much look forward to seeing how in the very near future that the US will be able to contribute.
I am going to move us to our next question because we are getting a little short on time, and I know there are a few other topics that we really want to cover. Academic institutions play a really critical role in combating AMR, particularly with regard to training our human health, animal health, agricultural, and environmental professionals. IDSA developed a medical student curriculum on antimicrobial stewardship and began offering it to all medical students free of charge in April of 2020. So far, over 200 medical students have participated. We're encouraged by this start, but we recognize there is so much more to do, and the needs certainly extend far beyond medical students. Reshma, how would you characterize AMR education, and what more do you think needs to be done in this area?
Yeah, thanks for this question. I do have some other hats that were not mentioned, including sitting on the boards of the American Medical Student Association Foundation, as well as Universities Allied for Essential Medicines. And so, through our conversations with those organizations and their student members, and also in teaching a number of students at medical schools and other institutions, we've just seen such a wide variation really around education. And there is, an opportunity to think about how we can provide a standardized set of principles and curricula across these different institutions to really make sure that stewardship and antimicrobial even innovation and the principles around how antibiotics are even developed and the regulatory flexibilities that have been awarded so far can be a part of the educational system. It's been heartening to see some interdisciplinary efforts, not just with medical students, but nursing, pharmacists, and even with veterinary students really emerge in this space. But I think there is an opportunity here for collaboration, not just with the EU and the US, but really with countries around the world, to think about what are the primary components of a robust medical education system, as we've done in so many other areas with these organizations, to really impart the importance of antimicrobial stewardship around antimicrobial resistance in general, because right now it's not a compulsory part or even a prominent part of our medical education system. You really get thrown into the fire once you start practicing clinically and you're realizing you're prescribing these antibiotics and trying to determine which ones are appropriate. And so it can really be a trial by fire for a number of us once we enter into the clinical setting. And so I think having more of these lessons upstream would be much more fruitful in trying to make sure that stewardship and resistance and this issue in general is a part of the medical education system.
Thank you so much. I'd now like to ask a question that was submitted by a member of our audience. How can we best make sure that civil society, patients, and consumers have a voice in future actions on AMR? And I will add a little bit to that. I know that there's been a lot of youth energy around AMR, something that several of you have been involved in recently. So perhaps you could speak to that as well when answering this question. Do we have a volunteer to take this one on first?
Maybe I could start and get us started. I mean, we have work also at the Johns Hopkins University School of Public Health. As part of our program, we support a intersectoral coalition of civil society groups that came together in 2014 in many ways, because the space is not one which is, of course, as well populated as you might have in other disease-specific areas. And so there was a real need to be able to bring together intersectoral perspectives together. What we find is very challenging, though, on the landscape for civil society, and this was, of course, recognized in the UN Interagency Coordination Group on AMR's recommendations. I was fortunate to be one of the co-conveners, and one of the things I was really pleased that we actually put forward was the need to provide financial, technical, and of course, other support for civil society to engage, because the voices of those, particularly from other countries in the South, but also in civil society more broadly across the board, they're very much not well resourced. And it's important in many respects to actually engage them in a way that allows them to be partners at the table to discuss, because most movements depend upon that mobilization. You look at tobacco control, you look at climate change. Really, you need to be able to bring, of course, these civil society organizations, the professional societies, and others, and mobilize. This was both a shortcoming, of course, noted in the comprehensive review of the WHO's Global Action Plan on AMR. It's one which we continue to struggle with actually as a movement to try to keep this actually issue and its momentum moving forward at this time. And of course, there's strong industry forces as well. We didn't really quite address actually that the industry also has economic incentives that don't always work in alignment with, of course, antimicrobial resistance concerns. And so we have to really take on a number of these issues in order to change the enabling environment for these groups to participate. But what they've done, like in the food sector, has been nothing short of amazing in terms of actually getting large restaurant food franchises to actually change their practices by reducing, for example, the use of antimicrobials in poultry. But we still have distance to go for pork and beef. And of course, there's a call now on McDonald's to actually maintain its actually commitments that it had made several years ago. But only with the voice of civil society will we actually have that kind of course of direct action needed to move this frontier forward.
Amanda, I'll jump in here as well.
Sure, very briefly.
Yeah. That's fine. Yeah, I just wanted to jump in terms of the civil society voice in terms of looking at innovation as well. There have been obviously a stress on these financial incentives for antibiotics, but I think a number of physicians who are part of organizations like Doctors for America, those who are part of the American Medical Student Association, National Physicians Alliance, and who have been monitoring these sorts of incentives. One of the concerns that has come up in looking at proposals such as Pasteur is that whether we're paying for antibiotics that are truly effective. From the research side, we've seen, looking at these antibiotics that have been recently approved, there are questions on whether or not they're truly beneficial for our patients from a clinical perspective. And so I think civil society has been raising this to the FDA and to Congress. And so these are voices I think that need to be heard, but across the Atlantic and really around the world, in terms of how we structure these incentives to make sure that we're paying for not just new drugs, but also new drugs that are clinically meaningful and that actually benefit patients from a clinically meaningful outcome.
Thank you, Reshma. We had one last question about whether a One Health approach is also being implemented in the United States. And I would very quickly say absolutely yes. Our National Action Plan does embrace a One Health approach, though I think we all recognize that we all have more work to do on all fronts. And I'm sure there is a lot more we could discuss on this important topic of AMR, but at this time, I do want to thank all of our speakers, all of our panelists, and everyone who joined us for today's event. I'm really looking forward to continuing to work with all of you to address the public health crisis of AMR. As today's discussion so clearly indicated, we have a lot of work to do. Claire, over to you.
Okay, thanks very much, Amanda, and thank you for guiding the panel there through what was a short, but I think very rich debate about AMR and the challenges. So it falls to me to thank everybody for attending and for your contributions. I think this has been a really constructive dialogue. We've had a high number of attendees online. Thank you very much to everybody who's been listening and putting questions in the chat, including some old friends I see, if I'm allowed to mention them. I think what the speakers have confirmed to us is that the challenges in the fight against antimicrobial resistance, they are multiple and they are varied. And we need to face them with an organized and a collective One Health approach. And I think I detected that we do share those One Health principles between the EU and the US. But obviously, we also said that the challenges are even greater with the diversion of resources and attention to COVID. I think Professor Anthony So called it a teachable moment. And I think all of us need to reflect on what we take away from that teachable moment. Obviously, from the EU side, we said we're advocating for an update of the Global Action Plan on AMR and an inclusion of AMR in the Global Agreement on Pandemic Prevention, Preparedness and Response. There were so many ideas that came out that obviously I can't do justice to all of them, but I would mention a couple, I think, which were important. And that is, I think, Larry Kerr, your suggestion about setting up sewage-based surveillance. And I think Professor Anthony So echoed that as well. And I think that is one of the lessons to be drawn from COVID. I think also what was mentioned was evaluation of the implementation of the Global Action Plan itself invites for more integration of environments, which we have been mentioning from the EU side, and also inclusion of UNEP in a tripartite alliance. So I think thank you very much to the American side for putting a furrow into which we could plant our seed, pointing out that there are already opportunities out there. I sense there's quite a strong momentum towards a partnership to work together to reinforce the tripartite alliance, including the AMR multi-stakeholders partnership platform, which we see as being important going forward. I think also Professor So talked about the need for more investment at global level to support the developing countries. And it's in this spirit that the EU is planning to contribute to the AMR Trust Fund. Not a huge amount we'll be giving there, but we will be giving some support to that. So I think that goes in the same direction. I think it's been a really excellent exchange. Thank you for the openness. Thank you for also having prepared so well for this and bringing so many thoughts to the table and sharing your ideas. I would just close then by encourage all of us to take this teachable moment, if I can use that quote, as a launch pad for a stronger EU-US partnership on AMR. Let's try and maintain the momentum and the dynamic that we've heard today to work collectively together for the well-being of society on both sides of the Atlantic. Thank you very much and have a nice evening, or have a nice afternoon, sorry, in the US, and have a nice evening here in Brussels. Thank you very much.